COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities.
For one night only, I will be the chair as Paul is leading the main session today. Aren't we lucky? This evening is going to take us through some key principles upon which COIN bases its thinking, really, and how COIN engages with the world. And then to help us reflect on those principles, we've some very good people from Brent this evening.
And in the last year or so, we've done a lot of work with government and associated organisations about the principles of making neighbourhoods work. And since they've become quite interested in that, I suppose today is the time to pull that together, and that's what I aim to do shortly. And my background is I'm a carer, previous GP and academic, and done a lot of work on systems development.
Thank you, Chris. Yes, so my name is Duke Tran, and I am a Adult Social Care Transformation Programme Manager in Brent Council, which is a council in West London. My history, I suppose, with community work or this type of work is in community development as a social worker. That was one of the first things I've ever done in my job was to do community development as a social worker in Melbourne, Australia. This was over 23 years ago. When I graduated as a social worker, and then even before that, whilst I was studying as a social worker, I was really much involved in community development because that's my passion. And the community that I really worked with was the ethno-specific Australian Vietnamese Women's Welfare Association, having an opportunity to start again as a migrant. Most of them were. My mum was one of them. I was one of them. Actually, we were refugees, in fact, and it was buzzing with energy and people wanting to make changes in their lives and in the community. And it was great to be part of that. And that really instilled in me an interest in this focus around community working. And when I came to the UK over 23 years ago, it was a very much statutory focus, and then helping people to find care homes for their loved ones and home care packages. So it's a very different focus. But as a transformation program manager over the past 4 years in Brent, I have an opportunity to work with people who are like yourselves in many respects, and Gabriella is one of those Brent colleagues that I've discovered in my journey, who is really inspiring. And that's brought me back to this community-orientated kind of focus. So we've been doing a bit of work in the co-production community partnership program, and I'd like to talk more about that today.
My background is related to audit. So I used to work in contact centers as quality manager, and I used to implement quality processes to evaluate outbound and inbound communications, selling products, promoting services, connecting people, and informing people. As well as I had the opportunity to work in the IT environment. It was a lovely experience. I had the opportunity to work for Tree Mobile as a service desk analyst in Reading, which gave me an insight of the community, of English culture, and learning a little bit more about the services. Yeah. And then comes health. And health is related to what I always did in my life, which was connecting the dots, connecting residents, connecting services, encouraging progress, and challenging what existed. And when I came to the UK almost 9 years ago with the 3 elements of the team called kids, 2 girls and 1 boy, I had the opportunity to volunteer with Brent Health Watch.
Okay, very interesting.
Why? Because I was curious to understand the health system, because my oldest daughter, she has different health conditions, asthma, bronchitis, eczema, which requires loads of attention. And I was concerned and I didn't know what to do. I went to my GP and I did the full process, but something was missing. And Brand Health Watch gave me the opportunity to go in 2 different settings, health settings, to listen, to hear from the people. Evaluation, feedback,
Very
criticism.
good.
So I could report back to public health within the council. And what happened? They discovered that I speak Portuguese because I was born and raised in Portugal.
Ah,
And imagine, oh, what happened? They were looking for someone
yeah.
who speak Portuguese, who could support the Portuguese community in Brent.
Access that
Can you
community.
imagine?
Absolutely.
COVID came. They found the Portuguese with loads of background in community engagement. Please, can you volunteer with us?
Very interesting.
So 2019, everything happened. I went to Alzen Methodist Church to deliver the COVID-19 vaccine.
Yeah.
And
Amazing.
when you find someone who speaks your language, everything becomes more easier.
Yeah, interesting. And Health Watch is interesting from, I don't know if it was a social enterprise itself, the Health Watch there. Was it a community interest company or something, or just part
It's a
of?
community interest company. Used to belong to Brent, then passed to advocacy project, now
good.
belongs to advocacy project. So they are connected,
Very good.
and public health funds part of it.
Having come to work as a GP in Brent 40 years ago,
Wow.
but to start 50 years ago when I started my clinical medical training at the Middlesex Hospital, a radical student union organised all the different schools, which were then not all connected with universities, into one student union and negotiated a joint multi-professional module in geriatrics, as it was called then. And I was really taken with this and enjoyed it and picked up the degree of resistance against it, particularly from the medical school and the doctors. But I picked up the importance of team working and making sure that the patient remained in the centre of our attention, and that we worked around and in the service of the patient. And that's gone with me all my professional career and afterwards. As a student, we went to Central Middlesex Hospital in Brent, and I did one of my house jobs. That's a 6-month post-qualification job in medicine at Central Middlesex Hospital. And subsequently, as a GP in Brent, I referred patients there. So I developed good friendships and working relationships with many of the consultants. And funnily enough, Central Mid had a very strong history and culture of collaborating with primary care. Now, I recently met up with the then once chief executive of Central Middlesex Hospital Trust. We're going back 35 years. So John Pope, who got so friendly with the GPs that he's now ended up as chair of the National Association of Primary Care. And that says something about the commitment to that. And I was, for a year or 18 months, part of a doomed project in integrated care between some consultants at Central Mit and local GPs. I'm happy to talk about that. It probably wasn't the best idea, but I'm so glad I did it because it made me think so much and understand some of the issues around integrated care. I headed up a campaign for an age-friendly Brent, which launched 2 months ago, and is all about involving older people, giving older people a voice, and a voice that's heard and listened to.
I did 9 years with the Royal Army Medical Corps as a nurse. Then I came into Civvy Street and did the next 40 years with in orthopedics and trauma in the medical device industry.
Wow.
I retired in 98, and since then I've been part of patient forums, chairman of the Bedfordshire Link and Health Watch. I continue to be part of the National Joint Register patient network, and also the Royal College of Physicians network.
Wow.
And I still do occasional talks on falls and fracture prevention to groups of older people.
I can claim to be a son of Brent, Chris.
Amazing
I was born
job.
and raised there. So I was a patient for 21 years. And then I was at Middlesex too, I think a couple of years ahead of Tony.
Amazing. John, it's always good to have you. Was your practice in North London, or is it in North London or South?
No, I'm now transpontine since I'm south of the river.
Yeah.
My 3 kids were all born south of the river, so I'm afraid I've left Brent long behind, sadly.
Do you want to say a few words?
Hello, good evening. Yes, I'm Zinat. So I represent an organisation that's been based in Brent since probably 1989, but I haven't worked for OPDA myself. It's Asian People's Disability Alliance, but I have worked in Brent, I think, since 2006.
Yeah.
So it's I've been 20 years in Brent with various. So some of the names and the places that you're referring to rings many bells. Excuse me, my camera's off. It's just I've got childcare duties, so I'm sure you don't want to see the mess behind me.
It's no problem. No, cameras on or off, or welcome. So, Zena,
Thank you.
Fantastic.
I'm actually I retrained as an end of life doula. I'd been a carer, and I also, prior to that, I'd worked for 44 years in film and television, running production companies, and also understanding what it's like to run different kinds of teams in different disciplines and dealing with difficult people. So to transfer to a slightly different, well, a completely different environment is quite challenging, especially under the sort of stringencies of the NHS. And it's a very, very different environment. But I'm just investigating various, for myself and for other people as well, investigating what integration is in this world of, and especially in hospice care, end of life care world, and bearing in mind that you know, via the work of Alan Kelleher, you know, the idea that it's the 95% rule. Especially in end of life, people are not dealt with. Only 5% of their time is dealt with by medics and medical professionals, and therefore what is it that you do with the 95% of the time, and how do you manage in a community to support people and the people around, perhaps those who are not dying, their families and their friends, and how you integrate and support within community.
Helen Northall from PCC. Really pleased to be part of this group, even though I tend to only join for short times and I will have to disappear by 9 o'clock tonight. PCC is a community interest company. I'm the chief exec, and we're really pleased to be supporting COIN. One of the websites that we manage is NHS Networks, and we've developed a web space for COIN on there. And the reason I'm late is I've actually been preparing the newsletter and blogs for this week, which is COIN Blog 4, where it's about neighbourhood health, getting started, goes to integrated care boards and anybody else who wants to sign up for it, which includes PCNs and practices. We also have quite a few people in Wales that we work with across health boards and across their clusters, which are of course very similar to neighbourhoods. We do work across healthcare, public sector. We do quite a lot of work with the Home Office as well as healthcare, actually. And it's about our social return is to provide that network to host organisations such as COIN.
At the moment, I am largely working with adult social care providers. Interestingly, just spent the last couple of months around fee negotiations with local authorities. So an interesting kind of space in terms of how you absolutely rely on kind of independent provider kind of provision. It needs all parts of the system to work effectively together to deliver that joined up kind of care, but there are some inherent tensions built into that relationship. Also of interest to a couple of people, my background is I was a senior manager in Marie Curie, so I ran end of life services across the east of England, and also looked after Liverpool Hospice and some of the London community services at various times. So,
well, the reason I'm delayed is because I've had a fairly circuitous, difficult journey back, having been to my beloved Everton last night, but I'm now back safely in the northeast.
You're watching Leeds against Everton, were you?
Yes,
Yeah. Well, good to you. You did get going in the second half,
that's
David.
true. After a disastrous first half for us. Anyway, I've just managed to get back because it was a late kick-off and I stayed overnight and just got back. But the weather's pretty awful out there. Anyway, basically, I was a former GP. Was for nearly 10 years the National Clinic Director of Primary Care at the Department of Health in England, the so-called Czar. Had a bit of academic attachments, was a former local councillor, and many years ago, failed Labour parliamentary candidate. Andy Burnham, eat your heart out.
COIN is a network of people who think and act, which we call practice, to bring about integrated working, which is why we come up with the idea of community-oriented integrated practice. And practitioners of this are able to produce infrastructure that helps people to interact. That means seeing facts as snapshots of complex stories in evolution. That's a message there for the research people, that facts do not stand alone. Sees change not as something incremental and linear, but as complex incremental transformation, as everything slowly and incrementally moves in response to changes in everything else. Multidisciplinary team working across agency, systems thinking, systematically developing trusted relationships, and that's a place where a continuity of care starts reappearing as a very important feature. Moving between focused detail and bigger pictures to form stories that make sense to people, and embedding cycles of collaborative reflection and coordinated change. We arrived at this place, I think, originally by talking about, well, what are we trying to do anyway? What's health all about? And we want to remind ourselves that we human beings are storytelling animals, as Alistair McIntyre might say. We skip between different stories, between a unique and complex sense of who we are. And perhaps using the biopsychosocial, spiritual, economic and ecological aspects of health to move that forward. And that, sadly, has been interpreted in very linear and compartmentalized ways. So you have doctors doing bio and psychiatrists doing psycho and priests doing spiritual and so on. And what COIN is trying to do is to bring those together. And you do that by the idea of a story and a journey. So if I'm on a journey, let's see David Colantoni up in the northeast of England, I can't get there if my leg is broken, bio, or I'm very agitated, psycho, or if he won't let me in, which is social, or if I'm not sure why I'm going and embedded in things, or if I can't afford the fare, which is increasingly likely with the way the trains are going, or indeed the ecological, if there's bombs on the route. So all those things actually matter, but they don't really matter on their own, accepting in the context of a journey. And this is the piece that seems to gets missed by all of the compartments. And that's the thing that COIN is trying to do something about. So on this slide, I've got initiatives that are actively being developed by COIN members, and on the other side being considered. Team working around the homes where a carer lives. And this is something I hope we might be able to make happen in Brent and also in other places. 1 in 10 of the population is a carer, which probably means that 30% of the population of houses have a carer in them. The carer, the cared for, and possibly on average one other. Those people land in that job without being prepared for it, without wanting it necessarily, completely out their depth and stressed, and unable to meaningfully relate to the professionals in any broad sense, accepting bit by bit. So they've got their own GP, except they don't know who it is, their own palliative care nurse, don't know who he or she is, and so on. We propose that those professionals form a team of named individuals, disciplines already involved, but named individuals, continuity of care, in order to form a team around that household. So we use the house, those 30% of houses, as a shared developmental space to form team working between GPs, district nurses, social workers, faith traditions, palliative care, specialists, whatever, so that it starts seeing a rounded sense of health for the whole household. Community health and wellbeing workers, and we've got Gabriele on the call. We'll be hearing from her soon. This is an initiative that is originated from Brazil, where locally embedded community workers go house to house, helping people to solve all health issues and identify them. Connie Youngens and Matt Harris from Imperial College and Westminster are leading the development of this model in the country, and we hope to hold a COIN meeting on this quite soon, as well as perhaps developing it in perhaps Harleston. Safeguarding approaches that develop communities, community being an amalgamation of the with unity coming together. And Duke has already led a meeting of social workers in Brent to say, how come that social workers, when there's a safeguarding issue, simply focus on whether there is or isn't a safeguarding issue and don't see the developmental needs? Because if there is a safeguarding issue, then there's a development need for people who are being abused or abusers. But if there isn't, there's also a safeguarding need because something has come to people's attention. And this is at the moment being completely ignored by the social services. So that needs to be changed. Through Sanjeev Ahluwalia, the University Change Anglia Ruskin University, students learning about healthcare and complexity as well as treating diseases, and neighbourhoods of about 50,000 population, the new government directive. And I think we've got Josefa from Brent joining us soonish, who's leading that area for Brent. On the other side, age-friendly boroughs, Tony's got something to say about that, faith communities, digital technologies, local people collaborating for healthy environments, and housing strategies have inbuilt into them community development. This alters the way of thinking about policy away from very specific compartments to have relationship building at the centre of policy. Good policy must enable relationship building between individuals, but also between different ways of thinking, between research and development, between learning and change, between heroic and facilitative kind of leadership, between different cultures. Part of that relationship building is going to be between these three paradigms: simple, complicated, and complex. Paradigm, of course, means a way of thinking, making different understandings about the world. Simple, complicated, and complex is comes from the mathematical literature, but it looks awfully similar to the literature on evaluation put forward by Egon Gruber, where he'd say positivism, critical theory, and constructivism also reflect these three quite different ways of thinking about the world. Simple thinking sees connection between different compartments, gives a sense of stability, but it duplicates effort. It fails to understand co-creativity, and it demotivates people quite often. Complicated thinking does see interconnected factors, which gives a sense of a whole, but it makes people trapped inside those systems if you're not careful. And it doesn't see how those wholes can evolve. And complexity thinking sees co-adaptation, giving a sense of creativity and freedom, but it requires broad engagement. It confuses those who are used to more concrete ways of thinking and is easy to hijack. So all three of them are needed, and all three of them have problems. And community-oriented integrated practice needs to and does integrate all three. Part of the training about this has to be, how do you do that? So the challenges are evaluating neighbourhoods in this way of thinking, community-oriented integrated practice, integrating the different ways of thinking, embedding processes that enable collaboration and training for it. There are major opportunities that are relatively new. The neighbourhoods provide an enormously big potential to work with these ideas because they are shared geographical areas. We've got the possibility of grabbing that potential now. Theories already exist now to do this. 10, 20, 30 years ago, most of this was extremely eccentric. Now it's pretty much standard theory. Dissatisfaction with the dehumanizing, expensive hospital-based health services is leading to a clarification of a need for change, a desire for change, and a desire to scale is leading to what we're doing, or I'm trying to do right now, which is say something about the basic principles that underpin all of this. So that comes with things like reframing research and development as stories and evolution. I won't go through all of this, just pick out a few bits. But orthodox thinking imagines research and development to be related in a linear way. You have research and it leads to development, evidence-based medicine. evidence-based practice. But this doesn't help complicated and co-evolving situations. It doesn't help real life. It helps laboratories and it helps the careers of various academics. Much better to see evidence as snapshots of storage and evolution, food for thought, guidelines, evidence-based medicine, artificial intelligence can all be seen as snapshots of longer-term co-evolving stories. And simply by getting people to agree with that, a lot can happen. Further reading down here, so okay, I could go back to Heisenberg and McIntyre and Darwin. Darwin, of course, didn't really say survival of the fittest. And, you know, when you go to the gym and you see a man with great muscles on, you say, you look fit. You rather forget that the term actually came from Darwin, or that period, where fit meant when you fit in well, which is why the giraffe appears as a model of his. The giraffe did not beat the lions by bopping them on the head, but by being able to reach the leaves that lions couldn't reach. So the term fit has been hijacked by linear thinkers, as has so many other things. The paradigm problem as it affects medicine, I wrote a paper on that last year in the British Journal of General Practice, has found some interest. Fourth generation evaluation, I suspect that this is going to be one of the great books of the 21st century, and I do hope they can get a better page on it, because it front page, because it looks a bit ugly, but it beautifully describes the problem with the first three evaluation paradigms, and then explains how do you do it for the 21st century. And essentially you bring lots of different kinds of evidence together to a sequence of workshops where people are able to reflect on the implications for their stories as individuals, their stories as disciplines, their stories as neighborhoods. And I'm hoping we can work with that idea in Brent. Cycles or spirals of collaborative learning and coordinative change could well be something that policy can embed everywhere to bring some of this about without necessarily having to understand the theory to the level I'm trying to put it forward at this moment. Essentially, if the world is that changing, that complex, moving forward, you can't predict anything. People that say you can really need to go back to page 1 of the philosophy books. But by having a sequence of staging moments, workshops, time away, reviewing complex change, you can, because you constantly adapt in response to other people, and you can structure that to incrementally transform whole systems of care or a whole neighborhood. We will need to reframe leadership as sense making. That's an idea put forward particularly by Carl Wake, who incidentally is the person who brought back Kierkegaard's idea of 1850 to say that this is a terribly important theory, that people mistake the seeming certainty of yesterday with the complex and emergent process of living life forward, an idea that still hasn't been understood by hardly anybody. It was Carl Wake who brought that back in 2009. Restorative and transformative justice has got a lot to teach us here, and Jerry Gorman isn't with us today. She did a coin session last year. Essentially, this, if you think of the truth and reconciliation programs of South Africa and other places, you essentially find ways for the accuser and the accused, the abuser and the abused, the different perspectives on things to come together in a facilitated way to start to understand something about each other and their responsibilities and power and so on. And this can become an empowering thing, far better than our fault-finding complaints processes we use at the moment. Equality means, in the first instance at least, being able to look somebody who's different in the eye and feel comfortable that you are equal. You're able to interact creatively with each other. Exactly what you have financially or academically or whatever is a secondary consideration than actually being able to look at each other as an equal human being. And you can do that with children, and you can do it with people of great age, as well as of different backgrounds. So this is the image we've discussed before. On the left is what we all experience of being absolutely overwhelmed by stuff, and people naturally need time to go under an umbrella, and we call this things like sleep or weekends or holidays. Now, that natural need to escape from the madness of being overwhelmed, to review things with different people, can be embedded inside policy as a way of running the world. And this is advocated by learning organizations and fourth generation evaluation, that you repeatedly go under umbrellas, safe places where you can explore things in some depth in order to make broader sense of your daily madness. And by connecting those multiple umbrellas in different parts of a neighborhood through things like large group interventions and different overlapping work groups, you're able to get ideas infiltrating each other. And just one last little thing there. You see the box on the left-hand side locked on the front of the screen. Under the umbrella, you see that being opened, because an awful lot of the noise that goes on in meetings and everyday life is not touching the things that really matter to people. They are very often superficial, or what people think they're supposed to say, or what people come out with first. You actually do need a time to stand back and think about actually what really do I mean in this? And that piece is presently missing, as far as I can see, in pretty much all policy. I just want to make the point here, why does community-oriented integrated practice work and worth working with? As well as everything I've just said, traditional professional practice uses focused initiatives. Now, these rarely motivate people outside of that focus. So it naturally produces compartmentalization of whatever you're doing, which reinforces the notion of linear, compartmentalized, unequal society interactions. Cycles of collaborative learning and coordinated changes can challenge this in order to present a new way of thinking. So you still get boxes, you still get focus, you still get projects, but they don't go in to the arena. They come out of cycles of inquiry, stay there for a little while, and the cycles of inquiry allow things to move on again. And below there's a load of references of people who've said that in different languages.
There is a lot of science, obviously, behind. There's a lot of thinking, a lot of science, which you're building upon here, science. And you mentioned, Goober and Lincoln, there's things like you often talk about the Alma Ata Declaration of 1978 and those sorts of things. Is it worth just saying a little bit more that there's such a lot of thought around this, but there is some structure, and that structure comes from some of the science that you've spent actually quite a lot of years thinking about.
Paul, it's brilliant, but there's a but. It depends who you're trying to communicate with, because we're all embedded in this process, and I've been through a lot of this thinking with you. You've been our sense maker. But if somebody new came to that, it might be a bit overpowering, and it depends who you're aiming it for. But in terms of proselytizing, it would frighten a lot of people, or certainly, because it's quite complex and stuff. So I think it's a brilliant set of slides, but in a way for the cognoscenti already. And I wonder if it's right for new people to be sucked in.
That was exactly what I thought. I came across that sense, the slide you had on kind of sense making and storytelling, and there's one part of that which is about the narrator, but the other part of that is about the audience. And for me as the audience, that was great, because I was doing some notes on a couple of things and I haven't read that bit, I'll Google that later and whatever, because I'm engaged and I'm interested in this thing, and even if they're not things I'm used to, I want to engage in ideas. Whereas I wonder for a different audience, there is something that is a slightly kind of different story that needs to be told.
So I just personally wanted to say thank you very much. That's actually a refreshing presentation, and definitely not an AI generated, which does get my goat, because that's all I ever seem to see nowadays, where the speaker and the content is so generic, you don't actually get anything from it. So I think in terms of its depth and its a reach, it's great. But yeah, maybe just as others have said, maybe sort of some differentiation between sort of the sciencey part to the part that and dependent on the audience. But for me, I absolutely enjoyed that, and thank you, Paul.
Lovely. You know, I've grown to know Paul and Coined, of course, over the past I think 8 months now, really, and a bit more actually. What strikes me is that here lies an opportunity to really reflect on the language that we use and the terminologies that we use. And in my world, there are almost like 3 competing kind of language sets or cultural sets, really, when it comes to coin, and the challenge of conveying complexity. One is that very academic and research-based language, which is lovely, and we can see that in the presentation. The other is the kind of more government standardized consultancy language around project management, etc., which I'm very familiar with, and I'm sure most of you are as well, who are in practice or who have experienced that. And then thirdly, there's an emerging language that I feel that we need to really be aware of, and that is the language of communities. And as we move into neighborhood working, we need to be conscious that the kind of paradigms and the kind of language that we use need to also make sense with the people that we serve. And I think that is increasingly more pertinent. You know, I've been developing presentations, and often at times I have to look at the acronyms that I'm using, the kind of language that I often associate with in management and consultancy speak as a local government officer. But also potentially as a researcher, we also need to do the same. We need to think of, well, how does this relate to, the people that we are working with? So that there are 3 competing areas. I think that's really important. But what the slides have shown, and thank you, Paul, so much for putting it together, is immense wisdom and insight from many years of thinking on this. And it is complex. It's not easy to explain. I find in meetings that it's difficult to explain processes. It's very easy to say the theory of change is this: you start from here, you end here. You do a survey. The survey says, all right, 5 out of 10. Then you do your bit of work, and at the end of that work, you do another survey and it says 8 out of 10. Oh, I've improved. But what it doesn't do in the theory of change is it doesn't show you that journey of learning, that journey of change. And I think, trying to describe that is complicated. It can often be very complicated. And so, this kind of work here that Paul's doing and we're trying to do together here is trying to bring that insight into this work, right? And I think that is our challenge. And also that is our opportunity to, this is the time for it. This is the time to bring back realism, bring back, the language of communities into this work, because often, I think we've disassociated ourselves either into the academic field or into statutory services, and we're all just thinking about thresholds and criterias rather than people and communities. And here lies an opportunity for us to start thinking in this way.
A lot of things don't show the journey of change. And yet when you look at Paul's slides, I think a lot of them are actually trying to point out the fact that the normal stuff doesn't show that journey. But the way that you put it there is really, fantastic.
Thank you. I just wanted to touch upon the language that we were just all discussing and where the community come in. But I think Paul's presentation is key in that it's reinforcing the fact that the community have always worked in that way, and the work that Gabriella's been doing, I think it's just highlighting that the community themselves have always helped and looked at people and gone in and supported them in that holistic manner, looking at all aspects. So I guess for me, from the community, as delivering on a day-to-day basis, I see what Paul's presentation is just reinforcing the value that we've already delivering, as opposed to you're trying to educate the community, because I don't really think the community need the education in the way of the presentation.
I'm extremely encouraged that I haven't heard anyone say there's a big flaw in the argument. Now, if anyone can think of something, please let me know, not necessarily now, but afterwards, and gently, please. No, you can always say, I may be wrong, but if it is wrong, I really need to know, or if there's a big flaw in it. If the problem is really how it gets communicated, and it just may be too much for people to absorb, that's a different issue than if it is actually wrong. You don't make it better by carving bits off to make it seem simpler for people, because you've now done the very problem you're trying to escape from, is to cut it into pieces. So actually, you kind of have to get the whole thing rather than... So that's the first thing. So we have to get it in, I think, by stealth. And I just loved what Zinat said just then, because I think this is common sense. I think the high-founding academic words and references are disguising the fact that when you're faced with a bomb in the room, or somebody dying, or a family catastrophe, it suddenly becomes barred or obvious why you need someone to pat you on the back and say well done, or to help you have some respite, or develop a team around it. Or so by reflecting on difficult situations, you know this in your heart, and it's just giving words, I think, to common sense. The trouble is that too much theory is made by people who aren't embedded in experience. So people like Gabriella and Zinat, for example, who are embedded in experience all the time, my guess is sort of get this in their bones, whatever. So I believe, or I think, or I hope, or I'm putting it to you, that trying out the idea of carers, the homes where there's a carers, which are almost always one of the most dreadfully difficult situations, linking them to all various members of the teams, GPs, social workers, doulas, and so on, could be the Trojan horse. Because everyone is forced to look at the complexity of it that they ordinarily would put on the too difficult to look at pile. And we can demonstrate by gathering data throughout a neighbourhood that it saves hospital costs, it improves the quality of care, and it improves compassionate neighbourhoods, communities, because people start to appreciate difference.
Is that many people are hurting, so they don't bring their best self to every communication. And it takes a lot of grace to work in this way. So don't underestimate common sense isn't that common, and I think the whole thing needs to be a healing process.
There needs to be sometimes a fly in the ointment that says, buzz, something's wrong. And when we talk about common sense and getting people to describe their own issues, I think the point that Kevin's trying to make is sometimes it's just impossible to articulate when people are suffering and when they're coming across something they haven't had to come across before. And it's so hard to put words into it. And I want to come back to something that I know that Paul has said, and I firmly believe in, which is about creating space for people to think and talk, obviously. And the importance of, when we work with whoever we're working with, but particularly with community-orientated care, that we are allowing people space to talk and to think and to make sense of what's going on in their lives, even when it's desperately painful.
Right. Thank you. Okay.
Yeah.
All right. So The Co-Production Advisory Board is a governance board which forms part of the Co-Production and Community Partnership Enabling Program in adult social care. In adult social care, we've got a transformation board that sits on a monthly basis, and it has various programs that we try to implement to make changes, like, for example, improving digital access for residents and supporting residents with digital tools we've launched recently, looking at how we can maximize people's independence, etc., looking at early help resources, etc. So we've been doing that for some I think for maybe a couple of years now, really. And I was leading on the co-production and community partnership program for most of this time. I was particularly interested in looking at relational services and how do we get that humanity back into services, particularly as we are approaching more of a focus around neighborhoods and neighborhood working. So what I'll do is in the chat, I'll just drop in the chat the kind of policy context that was dropped before Christmas last year by the Department of Health and Social Care that really dictated the 3 priorities that we should be working towards. I think priority 1 was more around carers, priority 2 was about personalisation, priority 3 was more around integrated care and developing integrated care plans. So that really focuses adult social care council departments into that integrated way of working with our health colleagues. And in that document, you'd see that it does mention the 10-year health plan as well, NHS health plan as well. What we have been experiencing is really a lot of fragmented support between services and variable relational practice. And there is a lack of evidence around strengths and community asset-based working. So if I was auditing a social worker's assessment of a person, it's really difficult to understand where that evidence base is for their analysis of people's strengths and community assets, other than the fact that they wrote down on an assessment form that they've signposted a person to a community resource. That to me is not good enough, really. We need to build on, what we mean by strengths-based and community assets. What we need to practice better and develop the evidence base for that. We also know that there are digital tools that can really help people and access communities that were harder to access previously. Young carers, for instance, people who don't normally go into the civic centre or a local authority service simply because maybe historically in their home countries, for instance, that wasn't the right thing to do. But equally also we know that digital can exclude people as well. So we need to work more with our voluntary and community social enterprise partners to actually engage with our communities with these digital tools. And then finally, there's a limited, I believe there's a limited really evidence base around models of care in neighbourhoods. And this is a time to develop that and to test and learn different models of care. But what do we mean by relational practice? We keep referring to that. So Josepha and I sat down. We thought, okay, I'm not sure if Josepha's here. If she can join us, then that would be great. I'm sure she'll be speaking to this. But what we decided to do is, this is not really inclusive. It's not exhaustive, and there are certain things that we want to say about relational practice, and you may have other points as well. What we want to express here is that relational practice really needs to start with a person to explore what their personal strengths and social networks are, where those connections are to their community, whether it's support or services. And there's a bit about motivational techniques, motivational interviewing and coaching techniques that can help people just move from where they are to a better place. And remember, this is coaching. It's not telling them what to do. It's encouraging them to find solutions for themselves, and that's really important. And also, it's about using your relationship with the person to facilitate that change and improvement. And finally, it's about learning what works, what doesn't work, and learning together. So the proposal at the moment is that it was a bit inspired, really, by a video that I saw recently of Peter, Paul's son. He went to Brazil and spent some time with the Brazilian community health and wellbeing workers. And from that, also, my discussions with my colleague Gabriella, who can speak a bit more about this. So I had thought about what we need is probably to develop the relational services model in neighbourhoods by working in a community health and wellbeing worker type way to scale innovative use of digital tools. Now, I'm saying type way simply because in Brent, we don't actually call anyone a community health and wellbeing worker. We don't have that. In Westminster, we do, and in other parts of the country, I think in Cornwall, they've piloted that, but we haven't. But we know that the community health and wellbeing worker model is actually quite encouraging because it starts with the person. It is not a top-down approach. Unlike other workers, you're told to go out there in the community, engage with the community, and say, "Oh well, in your part of the world, we need you to actually go and see more of your GPs and get tested for HIV or insulin, etc., etc." That's a top-down approach. What the community health and wellbeing worker model is about developing that relationship first. And then from that relationship, you uncover what is important to that person. And that to me is key. And it does, I suppose, speak to a lot of things that we have been trying to do in Brent under the Co-production Community Partnership Programme for the past couple of years. The second thing we want to do is to develop two high impact communities of practice in Brent, which can be scaled across Northwest London to support the pilot. And these communities of practice will be mutually reinforcing networks. The digital tools amplify the relational practice, and the relational practice drives adoption. And that's what we want to achieve in these two. Where do we get our confidence to start this even proposal? Well, we already know that in terms of the different roles that we have in Brent, we've got social prescribers in GP surgeries. We've got care coordinators, community engagement workers like Gabriella. We've got voluntary community and social enterprise link roles. And we've got carers, workers, etc. They are collectively function in a community health and wellbeing worker type way, even if they are called different things. So I think it's about identifying where we are now and also acknowledging that elements of the community health and wellbeing worker model already operate in Brent, particularly with the Portuguese community engagement worker. And Gabriella is going to speak more about her experience soon. Then we also know that the Brent Care Centre in Harlesden social prescribers are already using digital tools, such as the Better Care Online Self-Assessment and the Joy app, as part of their workflow, and it's integrated into that work. So already we're seeing people are using this, workers are using this, and it's really important that we try to find ways in which to support them. And finally, the relational service neighbourhood pilot and the communities of practice will align and strengthen these existing roles and these adoption of these tools. So what is the pilot? The pilot is one pilot. It's to co-produce a relational services in neighbourhoods by working in a community health and wellbeing worker type way to scale innovative use of digital tools. We're going to focus on these roles, these people, social prescribers, care coordinators, community engagement workers, local area network coordinators, voluntary community and social enterprise link roles, carers, workers, trusted assessors, etc. And we're going to use our What Matters to You materials, which Sky is going to help us develop. And that is about starting with a person and having that relational conversation. Kevin can talk more about that. We've asked Kevin through Sky to actually help us to develop the What Matters to You workshops, and he's been doing that, and he can talk talk a bit later about how well that's going. And then also what we want to do is we want to use the framework for evaluating change, which we co-produce with others on the board through a series of workshops headed by Professor Fiona Verity. And the framework for evaluating change is about what I've just mentioned earlier. It's to evaluate that shared learning and the journey of change using lived experience and storytelling. So, which is very different to the theory of change. These are the two communities of practice. I've mentioned that already, using the community health and wellbeing worker function to embed relational services delivery in neighbourhoods through what matters to you relational conversations based on strengths and community assets. And the second one is about scaling innovation and using the mobilizing the Better Care app, the Joy app, the Virtual Care Centre, which we're developing, and the Virtual Care Support, the telecare pilot we're developing, and Magic Notes. What does success look like? Well, we want residents to experience timely, person-led support in their neighbourhood. And it looks probably something like the consistent, what matters to you relational practice across teams and partners within the neighbourhood, increase uptake of digital tools by voluntary and community and social enterprise organisations and commission providers, codified learning and workshop to scale across North West London, understanding what skills, qualities, interventions, organisational structures and conditions foster relational service design and development. And we want to see the application of the Brent co-production approach and the framework for evaluating change. Firstly, Social Care Institute, as I mentioned, through Kevin, has been supporting us with the workshops, but we want to probably ask them to develop the materials for this going forwards for the next 12 months, and also the materials for the evaluation, the framework for evaluating change. I also would like them to also run 8 sessions. That's 4 sessions for each community of practice from now until August. COIN, in discussions with Tony and others earlier, and Paul, can act as a good friend. And that can also be a critical friend as well, to promote principles and practices for integrated neighbourhood care and support. And that may look like monthly mentoring meetings for our community of practice leads and workers, provide that space for reflective supervision, well-being, and crisis support. It depends really. I think what I want to say is it's really about giving us a space to really explore, these different practices and these experiences, which can be good and bad. And I think that's where the wisdom of the network comes into the fore and can really make an impact. We've engaged the impact group, so they're called Improving Adult Care Together, and they're quite keen to 2 networks that I mentioned, and that launch will start in September. So from now until September, it's preparatory, the development of an early phase community of practices. And then from September onward, they will be known as impact networks. And they will support the scaling of community of practice, moving into networks across North West London, and potentially to support with the development of business cases and funding routes going forward.
Just to share my experience adopting the model. So this model started in an innocent way 5 years ago during COVID. And what made sense for us was to identify the opportunities for services to improve services. And a need was identified during a COVID-19 session with a bus in a local place, Alsden, next to a church. 5 out of 8 Portuguese speakers from Brazil were not registered with GPs. Rang the bell. A conversation started. I speak Portuguese, born and raised in Portugal, so we could have the same level of conversation. Trusted person in the trusted place, linked to trusted services. This was the key message. And what happened was identify opportunities to empower residents with knowledge, with understanding and with energy to rebuild the confidence on the services. What I did was not register with the GP. Locally, I access to the NHS website because we use always iPad, and we were able to register those patients immediately with the services. At the same time, we empower them with knowledge because they were doing the registration, so they could empower others. It's not about doing for them, it's doing with them and for them. So, first level of the conversation, as we all know, public health is not about part of the individual, is about the whole individual. Why the social determinants was always the mission, and it will be always the mission. For that reason, I believe that this model should be the model to be adapted so we can engage, connect, and empower the full range of services already available in the community. After that, after deep conversations throughout the years, we identified that was not all about health, was about family, education for the children, English as a second language to improve access to services, to work, even to cultural activities, to integrate on the services. And after that, we identify, hold on, we have pregnant women with no connection to the services, with no support. So we had a different vision. Bring pregnant ladies. We are monitoring 5 babies at the moment that we supported since stage 3 months in the home of the mom. So we made referrals for St. Mary's prenatal. We are monitoring. We supported consultations to make sure that the services gave what was expected. So far, so good. At the same level, we are improving the services because we bring the evaluation from the patients themselves. How did they go the appointment? What didn't go well? So we can review it and improve. So since 2021, we identified a need in conjunction to many providers like Brent Health Matters, which is an extension of public health, is a clinical site who come with a variety of clinicians and empower my knowledge, empower my understanding, so I can link to the community and empower themselves. And what makes sense was, in conjunction, all of us identify community assets, making those connections, maximize the work that we do with only one person. But again, the key element of this was the connection made with this. Have a Portuguese speaker, which is a receptionist, make things much easier. So language is not a barrier. Just to sum up and to close, make sense the model. Operationally, we can link already with the services, but what makes sense is to understand from the individual, children, neighborhoods and services, what is there, which will make their life much easier.
Thank you, Gabriella.
I think a lot has been raised about how to explain this to people who are not familiar with this way of thinking. And I think we need to go away and think about how to do that. I think John Climo said that very well and clearly. And we've got a fantastic network of people in political places who can help us, and we've got a borough that's up for this. That's quite a lot, yeah? So there may be a lot more to think through, but I would say that's not a bad start for.
Thank you, everybody. Thank you, Paul. Duke and Gabriella, thank you very much. Useful stuff, and very much linked with the obviously sort of general principles that Paul was setting out, and then to see Brent doing what they're doing, and the very clear linkages to all that, an incredible amount of work going on. So yeah, Paul, brilliant January. Thank you.
I think COIN would act as a home for practice, reflection, learning and wellbeing support, and I think that captures really the camaraderie and the kind of wisdom that's here. So thank you.
Sounds good, Duke. Are you happy?